Go ahead, Kanchan.
Yes. Good evening, everyone. Myself, Dr. Kanchan Prasad. I extend hearty welcome to all the stalwarts, all the dignitaries, and all the delegates to this ICOG New Frontiers in Ob-Gyn episode 2. And it's my pleasure to introduce convener for the program, Dr. Pratibha Singh, Madam. Can we have the CV, please? Next one. Yeah. Pratibha Singh ma'am is one of the very dynamic chairpersons. She is currently chairperson International Academic Exchange Committee FOXY, and she is consultant and laparoscopic gynecologist and IVF specialist from Bhagalpur. And she has been on many posts. So I request you, ma'am, to kindly welcome all the dignitaries.
Hello. Can you hear me? Hello. Yes.
Yes, ma'am.
Yes, Dr. Pratibha.
So good afternoon, everyone. And as a convener, I will welcome all our esteemed faculty to this ICOG webinar of Technological Advances in Ob-Gyn. Now, technology bridges the gaps, links minds, and innovates for a better tomorrow. And today we have stalwarts from our fraternity who will share their invaluable experiences and tips on incorporating these technologies to upgrade our skills. So without wasting time, first of all, I would like to introduce our Dr. Parul Koshawala. He is the chair of ICOG, and he is also the vice president ISOPAR in 2022. And he was also he is at present the professor and head of Ob-Gyn in Sai Institute of Medical Sciences and Koshawala Women's Clinic. And I'll request sir to kindly welcome all our dignitaries, all the viewers who have joined today for this ICOG webinar. So over to sir.
Thank you. Thank you, Dr. Pratibha. It is indeed a pleasure to have the second program of this episode.
Can you just unshare the screen? Hello.
And this, technologies are now so very involved in our practice. We see Dr. Sunala here. He must have started his practice when the skills were the prime. And now the technologies have taken over. And they have supplanted some of our skills. But I believe that the best combination would be most suitable for our patients. And basically, this idea is a brainchild of Sarita. She wanted a series on this technologies. And today we have three very big stalwarts going to speak to our Foxy, Narendra, and Alpesh. And Ruma will be deal with the robots, which is the rage these days. Almost everyone, youngsters, they want to take on robotics. And all three I know since so many years, and I know their capacity and potential. Thank you.
Thank you, sir. Thank you so much. And before I introduce our secretary ICOG, Dr. Jaideep Tank has not joined.
I think Dr. Pratibha, let's have Dr. Sonawala's
I'll
address.
request our esteemed faculty, Dr. Sonawala sir, to kindly just bless us with some pearls of wisdom. Sir, you have to unmute yourself, sir. Please unmute yourself. Yeah. Yes, sir. Yes.
Yes.
Yeah.
No, these webinars are absolutely a must because every doctor has to know everything, and the knowledge now required is not just from the books, but from the experience of other seniors when they tell the say problems and how they solved it. It's a very, very a good and interesting way of learning. When 53, I became a doctor, I joined medical college in 1948. 53, I became MBBS, MD in 56. There was nothing. We just had a stethoscope or a stethoscope and X-ray off and on. With great fear, we would use. And then came ultrasound, and then came genetics, and then came endoscopy and microsurgery. And now there is no limit. So what I would like to mention to the juniors, stick to one specialty and be a master of that instead of trying to be doing everything. Of course, in certain areas of the country, you might not be able to just practice one specialty. You have to have a wide specialty experience. But as soon as you become a specialist in one particular area, you might require a little time to settle down. But once you settle down, your practice will grow by leaps and bounds because everybody, the fellow gynecologists, will also respect you and call you to help them whenever they have a problem. The problem I faced when we started were criminal abortion. Termination of pregnancy was illegal, and there were young girls coming to the hospital, septic wards full. And that's why I put my hand into termination of early pregnancy with the help of Family Planning Association, of which I became a member very early in 65. And then came the need for population stabilization. So I started venturing on these IUDs to control population, and failures were very willing to undergo sterilization. So my feeling is that for India, the program still has to be female sterilization, vasectomy for the males should be promoted in the best possible way because at one time, 80% of the sterilizations were vasectomy. After the emergency, the vasectomy went down and laparoscopy came in, Minilab came in, so the tubal ligations became more popular. So our Indian program should be a spacing method, 2 kids to be promoted. Some may be opting for a third one, it's their choice, but we should aim at 2 kids, whatever, 2 girls, 2 boys. Nowadays, it makes no difference. And the girls sometimes are more superior. Not sometimes, most of the times are more superior and more achieving than the male sex is. So that is the message that I would like to give, that every gynecologist should get involved in controlling or stabilizing the population. I don't think I would like to speak more because once there are so many points one can mention, but at present in India, every day there are more than 675 or 80,000 deliveries a day. Infant mortality is there will be some loss, but just imagine, can we build a school for them when they require schooling every day for so many people and jobs for so many people and a roof over their head for so many people, food for so many people, 670 or maybe 600,000 people a day. So only way to save our country is to stabilize the population and bring it down. We were only 290 million when we got the independence. And now in 75 years of independence, we have gone to the maximum in the world, 1.4 billion, overtaking even China. I don't think we should be proud of that. It is, on the contrary, a big burden the country has now to tackle. Anyhow, whatever the future is, we have to face the problem and tackle it in the best possible way. And the lot of burden of this is to the obstetrician and the gynecologist of the country to control the population. So with these few words, I would wish the webinar all success. And to the speakers, please teach. And the more you teach, more you learn. That is the dictum we should have. Because the days are gone where people used to hide the main points, thinking that they'll be competing with me. But it's not the right thing. The more you teach, the more proficient you become. And please go ahead, give your experience, and teach all the Ob-Gyn people of India and maybe other countries to join in the webinar, whatever best you have done for the country. Thank you. Thank you very much. And it's a great pleasure to be a part of it.
Thank you. Thank you so much, Sonawala sir. And you have given a very valuable advice regarding the technology, regarding the control of population and teaching, which is I think the best part which doctors can do, and with the way we will experience, if we are teaching our juniors, at least they will be carrying forward the expertise what we know. So that is very important. We always been so much used to think about you that Sonawala sir is there. Now today he is there. For the first time I am meeting you. I am really very much honored to see you here. And thank you so much, sir, for joining. And please stay back for the whole of the program today. And with these words, let us go forward. And I think our Secretary General, Dr. Madhuri Patel, has also not joined. And sir has Dr. Jaideep Tank has also not joined. So now straight away I'll introduce our Dr. I think Dr. Sheila Mane, madam is there? No, she's also not there.
No.
So with this, I'll just introduce Dr. Sarita Bhalerao, madam. She is the whole program which has been conceived and designed by her only, and she is the force behind this ICOG New Frontiers in Obs-Gynae. So with this, let me introduce her. She is the secretary of ICOG, and she is.
I think I think that's enough.
Yeah.
And good
this,
evening,
I'll just
everyone.
request her to just give a welcome address to everyone.
Good evening, everyone. And it's a pleasure to be here. And I'm so happy that we are having the second episode of New Frontiers in Obs-Gynae. It's wonderful to see Dr. Sonawala, and I can also see Dr. Sanjay Gupte, our past president and past ICOG chair. And I would request Dr. Gupte to also say a few words. I'd like to thank Dr. Jaideep Tank and Dr. Madhuri Patel for giving ICOG this opportunity. And a big thank you to our stalwart speakers, Dr. Narendra Malhotra, Dr. Ruma Sinha, and Dr. Alpesh Gandhi. And at this point, I'd really like to mention that Dr. Narendra Malhotra is helping us to acquire these devices for the ICOG and for training. And that is why we wanted him to speak on these ultrasound to trainers. I'd also like to thank all our faculty. I can see our chairpersons, Dr. Sita, Dr. Kuldeep is here, Dr. Archana Kumari. And a big thank you to Dr. Pratibha Singh, who's done massive work in organizing this program, and Dr. Kanchan Prasad. So can I request Sir Dr. Sanjay Gupta to please say a few words, and then we will begin.
Thank you, Dr. Sarita. First of all, I must thank you and Pratibha ji for getting Sonawala sir to talk to us. It's such a wonderful, feeling that, having, seen him after such a long time. And he's just a personality who, inspires you, in whatever he speaks, whatever he says, has been a role model for me all my life. And so thank you, and thank you so much for having him here. And what apt advice, even now he, gives perfectly, for all of us, and he has actually right on the nail what the country requires. And I think we all forget that, this is something that is immensely important for the country. But again, we have such wonderful speakers. Of course, Narendra is there and he's always innovative, and he's going to speak on simulation, and Ruma is there on robotics, and Alpesh is there. So I'm not going to take much of the time of people in just this simple address. Let's proceed with the webinar. Thank you so much again for having me.
Thank you so much, sir. Thank you so much for joining. And I've been calling you again and again, but I could not get you. But thank you so much that you saw my message and you came. Thank you. And with this, we'll start our scientific program. And I hand over the session to Dr. Kanchan Prasad to continue with this. She is at present the North Zone Coordinator for IAC.
Thank you so much, ma'am. And now we move on to the first academic session. And to chair the session, we have two very efficient and very eminent chairpersons, Dr. Kuldeep Singh sir and Dr. Sita ma'am. Kuldeep Singh sir is renowned sonologist, and sir has received 4 awards and 3 gold medals in the field of ultrasound. And sir has authored 16 books on ultrasound in Obs and Gynae and infertility. And sir was awarded the Imaging Sciences Award at AICOG. And sir is currently successfully running Sono School for the trainers. So I welcome you, sir. And can we have CV of Sita ma'am? Dr. Sita Ramamurthy Pal ma'am, she is a consultant in fetal medicine and obstetrics, and she is a FICOG, FRCOG, RCOG, and RCR diploma in advanced obstetric USG. She ma'am is honorary treasurer, Bengal Obs and Gynae Society, chairperson Genetics and Fetal Medicine Committee FOXY, and fellow representative AICC RCOG Eastern Zone. And welcome you, ma'am. And now I request Sita ma'am to kindly introduce our stalwart speaker, Anand.
Thank you, Kanchan. Thank you, first of all, to greetings to all the seniors. It's a pleasure and honor to see Dr. Sonawala here. And my greetings to Dr. Sanjay Gupte, sir, Dr. Farooq Hurdawala, and Dr. Sarita Bhalirao, and the FOXY leadership. Dr. Sarita, I mean, this is a wonderful idea of having new innovations in the field of obstetrics and gynecology, and ultrasound is the first place where we are seeing leaps and bounds of advances. And I think we have the right and the apt person to speak on this. So I have the honor and privilege to introduce Professor Dr. Narendra Malhotra for this. And he's the Managing Director, Global Rainbow Healthcare. As you can see, it's an extensive CV, but Director, ART, Rainbow IVF, Director, FOXY, Smriti Manyata, Vice President of the Society of Ovarian Rejuvenation. But he has a number of achievements. ISAR Lifetime Achievement Award, FOXY DC Datta Award. He has been our FOXY past president, ISAR president, ISPAT, AOGS, ICMU. And sir, you have been a pioneer for ultrasound and an inspiration and a guiding force for all of us. So waiting to hear from you for the new innovations that we have in the field of ultrasound. Over to you, sir.
Thank you. Thank you very much for this kind invite and to speak on something which is going to be the future of training for not only ultrasound, for everything. And we're going to try to clarify what simulators are and what simulators are for learning ultrasound. Is my slide seen and is it moving?
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes.
So ultrasound is going to be like a stethoscope in the conf, and that should word go off. It is for us. It is a stethoscope, and that is what we need to make sure that all obstetrician and gynecologists are trained to use this stethoscope. What was the problem is why it is not becoming a stethoscope, and a lot of us are gynecologists are not using it because it's not in the structured curriculum of the medical colleges. And a lot of medical colleges and the departments still don't have an ultrasound machine in the OBGYN department, and it's looked after by the radiologist. The PCPNDT law does not allow us to do hands-on on patients till you have a MD, MS degree or a 6 months of house job or whatever. And there are 2 points where it should be used. We have 45,000 plus registered OBGYNs. There are at least about 1 lakh. The rest are not yet registered. And there are only about 15,000 plus radiologists. And looking at what Dr. Sonawala said, 600,000 deliveries a day, 600,000 antenatal scans a day, 15,000 radiologists are not being able, and we have to do our own ultrasound, and the obstetrician has to acquire the skill which should be there. What is the current scenario? The ultrasound machines, the good ones are expensive. There is a PCPND restriction. There is no recognized players for structured curriculum except for the ICOG and FOXY centers, which also we need to more structure them up and provide more strength to these programs. Patient consent, safety, patient does not consent to getting scanned by anyone, access, reach, lack of mandatory CME backbone, and lack of cases. The situation is exacerbated when the ultrasound has become portable. And very soon, India would have to allow these portable probes to be carried in your pockets and on your smartphones. And that is what the medical imaging will be. We are not yet allowed this because of PCPNDT. Even the transvaginal probe will be wireless connected, and the patient can take home and self-monitor her follicle response or whatever it is. So it is what is going to come. So we need to make medical education accessible to all our OBGYNs, and there has to be some hands-on training which should be there. So why stimulation is needed? Simulation is needed because there are barriers to ultrasound instruction and barriers to ultrasound curriculum. And driving forces for introduction of simulation into ultrasound is that you need to get trained on cases or real case scenarios. And that is what. So ultrasound simulators are then the wonderful paper which has been published in the World Federation of Medicine and Ultrasound, which we are a member of, which discusses the current views, perspectives, requirements, and technical aspects of simulation. Simulation has shown the way that it will clinically improve the learning outcomes. Ultrasound simulation already offers a wide range of training opportunities and likely to hold a key broader point in the care of ultrasound education for medical students, for practicing doctors, and for healthcare professionals who are going to be allowed to do ultrasound in India. So there are simulators for e-learning. There were cardiac simulators. There are HeartWork TTE model. There are HeartWorks pathology. There's HeartWorks START, and all these are already available. But they look at them; they're huge and they require a whole room, and they're very, very expensive. Unlike any other branch of medical imaging, let's say X-rays and all, ultrasound is unique because ultrasound cannot be understood by pictures or by videos or for this doing ultrasound, a person should be well aware of the anatomy, physiology, pathology, how to acquire an image, how to do the knobology. The knobology is so complex, knobology on it. That's why we try to give a knobology lecture and demo in all our training institutes, which Kuldeep is so good at. And then these people have to get a psychomotor skill or hand-eye coordination so that it can generate a very beautiful ultrasound image. And after acquiring all this knowledge, they have to put it in perspective in a reporting. So lectures were always there. We were always been giving lectures, and you can see some of the workshops which we've been doing, but you need extra hands-on. You need extra hands-on in a comfortable place where there is. So while interpreting image or sign loop of normal is useful, but then they might not be the only way out. And sometimes these people, the trainees who come there, who are fresh, need to know how to do the psychomotor skill is being taught to them. How to move the probe on simulators. There is no, if the patient is there, it will take hours and the patient will be not comfortable and may not allow this. So simulation allows training in an environment which is safe. That means there are no actual patients. Simulator allows digital technology of a new type of simulator, which we are showing you here, rather than the big ones. And this, look at how it's a real case. And it's a real case of early pregnancy, and that simulator is guiding you on where to put the probe, how to angle your probe. So it's digital and it's a virtual. Different type of simulation tools in ultrasound is that for training ultrasound is that you need a real device, so you need real patient. You have a real device, so you can get phantoms. Now, phantoms give you only one anatomy. You have a liver phantom, it gives you normal liver. It does not change the anatomy. It's just a still image. It's not a cine image. You have a VR simulator equipment, which the 3D and 4D ultrasound data, very good and very nice. But finally, you will land up into a PC or a smartphone, cloud-based, web-based, digital ultrasound simulator, which would be your best. So practical ultrasound skills require, as I told you, skill sets. And these skill sets will be cognitive, psychomotor, all the efficiency of understanding the probe movement, the right and left or side of the patient, and the various sections, the coronal, the longitudinal, and all that. So basically, there are two types of simulation tools. A part task trainer, which is the phantoms or the animals. And phantoms, I told you, is only one still picture. Animals, of course, do not, they might not be cooperative, and they do not mimic the human body. Or you have the full task simulators, which we call as the virtual ultrasound simulators. Now here, the phantom, you see the phantom could be of liver. This is only liver or kidney. Phantom is just a piece of equipment there, and when you put the probe in, you need a real machine with it. And you get that image. It's a still image, or a fetus, and you get that still image. It's not moving, it's not live. Or you have these virtual simulators which guide you, and which, in contrast to the phantom, they will provide different cases, extendable by software upgrades, and they will even provide you needle biopsy and everything. Here we're teaching you needle biopsy on these. So needle for CVS, amniocentesis, follicle, oocyte retrieval, cyst punctures, all that. So web-based, cloud-based simulators are a less expensive simulation device in a simulation setup. Otherwise, a simulator which you see, the still image or computer generated, which the various companies bring to the labs like GE simulator, costs you about 1 crore of rupees. And the other ones, still ones, of nothing is less than 50 lakhs or 60 lakhs. And it's you have to be very, very good. It's like playing with computer games. So virtual simulators are the ones with web-based which are required. Now, how do these work? They have a data source, they have data content, they have a hardware equipment, and they have an input device. And all these are integrated, and the patient data comes to you, and the patient knows it. So there could be 3 different ways where you could use ultrasound simulation. One is a 3D artificial objects created by a 3D artist, like you're seeing here. The second is a pseudo ultrasound generated, which various big, you see the full body and then you're scanning it. Those are all computer images. They are not real-time, real patient images. And the third, of course, is what we are talking about, is the real ultrasound 3D volumes, which are stored and which are labeled and which are scanned by expert and put into the software on the web, and that is where you go. So the choice of simulation equipment depends on how and what type of training or institution you have. You could have huge trainers like this, which cost 2-3 crore of rupees, but they are all computer. They don't have real patients in image. So you can do it for cardiology, for emergency, for visceral medicine, for anesthesiology, for pediatrics, for urology, for breast scanning, and of course for OB-GYN. That is what your choice of system is. And your if we go do a market search on what simulator to buy, there are about 435 commercially available medical simulator system which help in improving the medical psychomotor skill training. But remember, only 6% of these have a validated study and are validated for good medical aid. So we need to democratize the ultrasound education. And how do we do it? So it's education via simulation for ultrasound. And in this, we introduce the new concept, which is there, which we've been working very, very closely with Professor Gustav from US, Israel, and with our team in Bombay. And we have introduced the Voltcure Opus simulator. And that is how it looks like. And what is that? It gives you an optical positioning. It is an ultrasound simulator with actual image and an actual plane where you're scanning. See, this is a TVS probe, and there's a camera catches you optically where you are moving the probe. The guide or the GPS of the simulator gives you where to put your probe, right or left. And if you put it in the correct direction and get the correct size of the follicle or the cyst, machine says, okay. So it judges you also. And these are all real cases which are fed in it. How do we start it? You get this open thing. You open my courses. And once you open my courses, there are thousands and thousands of courses here. the course for crown rump-plane, the course for mid-sagittal view, the course for color Doppler, course for early pregnancy, course for nuchal translucency, ductus venosus, everything. Every possible course for OB-GYN is there. And this has been certified by the University of France, and now certified by the Fetal Medicine Foundation, by Nicolaides. And of course, we are trying to get this in our ICOG curriculum to certify it with ICOG. So that is how you go to the courses, and that is how either you can do a free scan or you can do a GPS practice scan. So very fresh patients put on a GPS and the machine guides them on how to. You don't need an instructor also for it. So that you check whichever probe you want to use, click on that, and you start getting an image, and you start focusing and scanning, and then the machine tells you you got the right plane or you've not got the right plane. See how the fetus is. We're going to do a measurement for the crown rump plane. So display, then you adjust, then you do the NT, then you do the option, and then you do on the screen, and the womb and the body simulation comes, the womb and the bodies, and then the audio guides you whether you are in the right plane or not, all automatically AI based, and then finally you can get the result whether you've done the right scan or not. The library is well stocked. Thousands and thousands and thousands of cases are there on the cloud library, which are accessible to anyone who has this simulator, and it is being upgraded every time. And those who are experts like Kuldeep and others, they can upload their own cases and their volumes, and they can form their own courses, and we can form their own course. So this is simulation for TVS and transabdominal ultrasound. And this simulator works for everything. I'm not talking of only OB-GYN, for head, kidney, liver, anything. But because we are here. And it's all AI based. So the artificial intelligence is used to guide you through this scanning method, corrects you if you're wrong, and judges you if you're okay, and finally gives you marks and certifies you. So a certain number of hours, if you want to get certified by the NEC University Paris, then you certain number of hours, 6 hours a day for 10 days for one particular course. That is what you get certified. So this is a high fidelity optical positioning simulator, uses real high resolution volumes. So real cases, that is very important. No other simulation machine uses real cases. Huge repository of normal and pathological cases, some 40,000 cases, allows a 6-degree freedom to move your hand, right, left, up, down, whatever, has an intelligent system, AI guided to guide you like a GPS. It's a metric system, so it will evaluate your learning curve, how fast the student is learning. It gives you a green flag, and the trainers can uphold their own volume, which I just told you, and customize your own course. So the benefits, it's very inexpensive way to train. There is no PCPNDT requirement. The structured course for beginners, advanced, very advanced. Cases on demand. You want an NT, you want a biometry, you want a IUGR, whatever case you want, you just select that case and that's it. No patient required. Compact portable machines can be taken everywhere into conferences, and you have a lecture and then a half-hour simulation for all the delegates, and then a lecture and then a half-hour. So they actually know what you've talked about and not just see. What we have been doing in India so far is, since we've acquired this and since it is now available in India, is that we are organizing training courses all over the country. And we have already have 350 OB-GYNs. Last 2 slides.
No.
To train about 500 by August is our target, and reach about 1,000. And we're taking it more step forward to go into each. And our target is to not only let them come here, we take the machines everywhere, and we are going to set up simulation systems which will include Opus, include laparoscopy, hysteroscopy. So a complete teaching institute you can make. And then, of course, it's going global. We were just presented in the American conference and around the globe. All OB-GYNs who are doing ultrasound and say, I'm trained, can take refresher courses and refresh their knowledge. And it will assess your skill and how you're interpreting the image, how you're documenting, how your medical decision is. All that can be documented. There are some pitfalls of simulators. I'm not saying it's the thing up. Simulation is not without pitfalls. The versatility, simulation experience, you don't have a patient, you're doing it virtually. You have to have a patient, talk to a patient. The conclusion and the take-home messages, ladies and gentlemen, simulation bridges theory and practice. So after theory of each lecture, you need to have a half an hour session or a 1 hour session on that, what you've learned. It is an ultrasound model, lifelike anatomy, lifelong learning. You have a simulator, you can put it on anytime, learn anytime. Ultrasound training is excellence in sonography education, and that needs to be provided. So my take to ICOG and FOXY both is that these should be available at all the centers which are recognized for ultrasound, infertility, prenatal screening, genetics, all these centers. And ICOG should take a lead to obtain this, because if you obtain a certain number, then you are in control and you can sublet it to the training centers. So whatever is being done on the training center is automatically judged by the experts sitting in the ICOG office, and they mark them. So there's no need of taking an exam. It is a skill assessment is done automatically every day when the training candidate is sitting on it. This will only happen when ICOG gets it and then sublets it. Or if supposing I am right now a center, I am subletting, and whatever cases are done on that sublet equipment come to me and I judge them and I certify them. So we are ready to dive into the world of ultrasound with hands-on simulators. This is, of course, real scanning, which is not possible with the PNDT Act. So you need to practice on real case scenarios, and that is what we are making our trainees do that. See how they're doing abdominal and vaginal scan on this. First, if you have the machine, the knobology has to be taught separately, but all the guidance, one-to-one guidance, one person teaching, standing behind them, looking at all that color, ultrasound, fetal echo, whatever course you want. And that is some of the things. So let's make our dream work. Let's collaborate and let's form a team which will make the dream work. Thank you very much, Sarita, for giving me this chance to express my view on simulation training and ultrasound. This is what is the...
Thank you so much, sir. It was such an informative talk. Now I request Kuldeep, sir, to kindly give some remark.
Fantastic, sir. We've been doing this. I'd like to first say a big round of thanks to Dr. Pratibha,
Hello,
Dr.
sir.
Sarita. Are you all able to hear me?
Yes, yes,
Yes, sir.
yes.
Thank you, Dr. Pratibha, Dr. Sarita, for giving me this opportunity. The seniors, thank you so much. Dr. Narendra Malhotra is a strong support system for me whenever we're looking in for ultrasound or doing it. So fantastic job, sir. And the thing about Opus is that we know ultrasound is always operator dependent. So the moment you're going to be showing them plenty of photographs, plenty of videos, plenty of spot diagnosis, plenty of quizzes, the first and foremost question is, how do I move my probe? So for moving the probe, it is the simulator that's essential. I know it's not the ultimate, but at least something or quite a bit of a thing is better than nothing. So once we're doing it, and I've myself done it with the transvaginal, and you know how to move the probe, you've done abdominal, we know how to move the probe. And in fact, in the same system, we're now going to have 3D probes so that even if you're going off axis, you can get lovely pictures. In terms of, even if you're doing a live workshop, let's say if supposedly we get an allowance of doing it, one will not be able to have so many abnormal scans, so many normal scans. The patient is not going to allow us to do a scan for 1 hour, 1.5 hours. So for that, these simulators are a must, and that's why it's needed. If I just do a cranial course, I can show them all the possible abnormalities because they're in the cloud. You can move the probe. I want to do an ultrasound of the heart, and there has to be a complete day's thing. They can all work on the fetal heart's normal plus plenty of abnormals. Fantastic job, sir, as always. Thank you so much.
Let me say something here,
Thank you.
Pratibha, if I may. See, Narendra is an absolute guru in ultrasound. But what we have to all learn is what he has, given us as an action, and that's why ICOG and FOXY has to, take up and follow the lead. And I'm sure he will be there to guide how this is to be spread. and then only it can be truly democratized. So not just to listen to the lecture and, say how great it is, but I think the action that he is advised, I think we must take up. I think that will be fantastic.
Absolutely.
Yes,
Thank you so much, sir. I mean, this is the way forward because we've done some courses with the hands-on school with the Opus, and the delegates, they absolutely love it. The feel of the way they move the probes, and then when the volumes actually come up. So I think when they can't practice on real time, and then they can use that knowledge when they go back and use it on patients and try. So this is the way forward. Thank you so much for the brilliant talk, sir. Thank you.
Thank you so much, sir. Thank you so much.
So now we can move on to next session, Pratibha ma'am.
Yes. Next, yeah.
I would like to invite the chairperson for the next academic session. Can we have the CV of Kanika Batra ma'am and Gaurav Desai sir? Next, yes.
Kanika Batra.
Just a minute, ma'am.
Yes. Kanika Batra ma'am is a gynecologic oncologist senior consultant at Max Institute of Cancer Care, Saket, New Delhi, India. And ma'am is a fellow IARC and IFCPC colposcopy. And she is fellow on ESGO Gynec Oncology, KM, and SN Germany. Ma'am is ex-visiting physician Mayo Clinic at Rochester, USA. And she has done postgraduate in the Department of Ob-Gyn, Vardhaman Mahavir Medical College and Safdarjung Hospital. And ma'am has authored numerous papers in gynec oncology in national and international journals, authored textbook chapters in gynec oncology, and ma'am has been awarded Young Doc from India from Asian Society of Gynec Oncology. I welcome you, ma'am. Can we have the next CV, please?
Thank you so much, Dr. Kapil.
Thank you, ma'am. And our next chairperson is Dr. Gaurav Desai, sir. Sir is gynec endoscopic and fertility specialist, fellow in endoscopic surgery and gynec oncosurgery, assistant professor at St. G.S. Medical College and King Edward Memorial Hospital, managing committee member, Mumbai Ob-Gyn Society. And sir has been bestowed with many prestigious awards like IAG Future Award, AOFG Young Gynecologist Award, Yuva Foxy Orator 2020. And so sir has 12 national and international awards in OB-GYN and 30 national and international peer-reviewed publication. I welcome you, sir. And now we request Gaurav Desai, sir, to kindly introduce our speaker, Ruma Sinha, ma'am.
Yeah, thanks, Kanchan. Well, what can I say about the speaker? I think Dr. Ruma Sinha is one of the most well-spoken and a teacher in the field of robotics and gynec pelvic surgery. She is, of course, an honorary professor at Apollo in Hyderabad, but also at the Macquarie University in Australia, and a fellowship director. She is the board member of the Asian Society of Gynec Robotic Surgeons and also on the editorial board of the journal. Welcome, madam. I think she'll be speaking on the road to learning robotics.
Thank you, Gaurav, for the kind words. Hi, Kanika. My regards to Dr. Gupte. It's a long time I'm seeing you, sir. How are you? Dr. Mehrotra, Parul, everybody from ICOG, Sarita, and all the colleagues and seniors that are there today that I'm, talking to you online. So it's really great to be here. And I'm so great that this Frontiers in Obs and Gynae was organized to actually talk about these things. We all know about Dr. Mehrotra and a wonderful talk on how to teach ultrasound. And I think simulation is the way forward to teach not just ultrasound, but also surgery. And robotics is actually taking a lead in how we can use simulations to actually teach the robotic surgery. So let me start sharing my screen here. And I've actually been asked to speak about what is the roadmap to training in robotic surgery at the moment. So this is actually a very common question asked to me by various of my colleagues, juniors, ma'am, how to learn robotic surgery. So I've just tried to make it a little simple and practical in this way of whoever is a gynecological endoscopic surgeon is looking to progress into robotics, what is exactly that they can, how they can proceed. So the question first arises that why do we need training? Now, we are all gynecological surgeons. We know our surgery. Why do we need a special training for robotics? Well, it's a new technology. The other thing you need to remember is there are more than one platform in this country and clinically for clinical use. So you need to know each platform, or at least the platform that you have access to. The concept is new, and the biggest concept here, which is different from what we have been doing all the time, is as a surgeon, I'm away from the patient. It's a concept that really sometimes mind boggles, because we have been so used to either open or in laparoscopy to be next to the patient, and we know that everything is under control. So when we are away, will that make a difference? Working with two energy sources is something which we are not regularly used to, even when we are doing endoscopic surgery. So the safety matters here. There is computer enhanced movement. So there is a computer interface between what you are trying to do with your fingers and hands and what is actually getting translated into the patient. So you need to understand this concept and use it to your best capacity to be able to deliver safe and effective surgery. And of course, because it's a computer enhanced, a big machine, there's so many factors to it. So are there any technical errors that can happen? Is there any faults that can happen? How would you manage this? So it's a big machine which sometimes can intimidate you initially in the operating room and think, oh my God, am I going to make a mistake with this? Or how am I going to handle this machine? But it is not that difficult. It's not rocket science. Goal of training is to make a surgeon safe so as to perform safe surgery. And that's the bottom line. There's nothing more to it than. So what do we know? Today, we know the concept of minimal access surgery, and robotic surgery is just an extrapolation or a logical advancement of an endoscopic surgery. So in our regular MIS surgery, we know how to prepare our patients for MIS. We know how to put up ports, how to position the patient in supine Trendelenburg position. How do we morcellate in the end and do exit strategy? And how do we post-operative management? So we know these steps. What is missing or what we need to learn is how do we learn this technology to use for these things? So the big commonest platform that's available today is the Da Vinci, which has three components: the patient cart, the console, and the vision cart. But as far as an audience, we should know that we have three other clinical systems available in this country. One is Mantra, called SSI Mantra from SS Innovations. You have Versius from CMR, Cambridge Medical Systems. And of course, you also have Hugo Ras from Medtronics. But remember what we don't know. We don't know that it's a slave robot. There's no automatic robot, because that's some of the concepts where obviously we as surgeons know, but most patients think that a robot will come and do some surgery. But it's just a slave robot. It's going to follow what you're going to do. And robots are often mistaken that they will perform, but they don't. So the technology part is what we need to learn. So you have to understand what is a patient cart. Now that is the real thing which is different from what you do in minimal access surgery in a laparoscopy. In laparoscopy, when we put a port, we put our instruments, we are right there and we do our surgery. But here, when you put the port, you have the robotic arms that come and stabilize these ports. And then you insert the instruments. These arms are then used and then moved by your console to be able to do using these masters, which is called masters because they are just like you're mastering your surgery through small movements which get extrapolated onto the patient. So this is what you need to master. Now you need to master as a surgeon the console. Now that's your basic. Whenever somebody comes to my OR for observation or I go to teach and I say, okay, you need to know the whole robot. You need to know the patient cart. You need to know everything. But as a surgeon, you need to master this movement. You have 1 to 1.5 feet square space. In that space, as you see, my arms are moving on those masters. I need to maneuver in that area, not get very uncomfortable, not go too far, not go too, but in that little space, I need to know how to maneuver my hands to be able to perform the surgery. And that is the crux of what you need to do. So that's the hand movement. And then you, of course, also have foot pedals, which will do the camera movement, which will have the clutch for you to move your instruments, which has electrosurgical pedals. So there are so many things on a console, which as a surgeon, you cannot do without mastering. And then, of course, you need to know how the patient cart will move, how it will come onto the patient, and what can be done. So this is the master, which you need to master. So who needs the training? When you think about doing the surgery, as a surgeon, I feel I need to train. But you may be wrong, because surgery is always a teamwork. The surgeon, the surgical assistant, the nurses, and the technicians in the OT all need to be trained together for you to be able to perform. So remember, as a surgeon, you have some roadmap, but you must create roadmaps for these three parts also to do. Additionally, you need to sensitize and train your anesthetist, because in the beginning, they are also awestruck that, the patient is under such a big patient arm. If I need to reach, how will I reach? And they start putting central line and so many things. But today in our OT, it's just managed like a laparoscopy. And of course, you also need to train your circulating staff, because what you're going to ask and expect from them is very different from what other OTs they do. For example, if there is a massive bleeding or there's an anesthesia problem, you have a big patient cart onto the patient. There is something what we call as an emergency undocking, and swiftly moving into the theater where you move the robot and take care of the patient. So the circulating staff is very, very important at that point of time to be able to help you as a surgeon to move from this point to the another. So you have to train the whole team to be able to do that. So what do you need to learn? You need to learn the domain knowledge, which is a theory-based knowledge, and then you need to know a technical knowledge of the robot, which is a practical-based knowledge. So let's see how we can do this. There are three groups of surgeons which require training. Number one, residents and fellows. Number two are those already who are exceptional or already good MIS surgeon. And the third are surgeons who are doing only open surgery, but want to move into minimal access with the use of robotic surgery. So what should be the pathway for the residents and fellows? Now for these, first you need to have an online self-module for about 2 to 4 hours, which will give you a basic theory about the domain knowledge of what is a robot, what are the parts, what happens, what you should do. And there's an assessment and online certification. This is usually provided by the device manufacturer. Like for Da Vinci, you have Intuitive. They have an online system where you can log in and do the online training program. And I'm sure that's true with the other providers as well. Once you pass on to this, then you do an hands-on session. That can be for residents and fellows. Usually we organize at our hospital, also in most places, small group. Take 10 students, do a technical knowledge for the equipment by robotic surgeons in partnership with the industry. And you can, in this group, also include your surgical assistant, preppers, and technicians, because it's a small group you're dealing with. The aim of this is to safe use of robotic equipment, learn the controls of the console, and of course, learn how to handle emergency procedures. After you have done this, then the resident and fellows are allowed to do a bedside assistance under supervision. Then they learn how to move the patient cart, how to dock the instruments, how to instrument exchange while the surgery is going on, and so on and so forth. After this, the resident and fellows slowly ease into coming onto the console and start doing surgical steps under supervision. And then once they do that, they can actually go for credentialing. What should be the pathway of a surgical practitioner? Now, somebody is already doing minimal access surgery, an excellent laparoscopic surgeon. But remember, you have to start with that online module, because what you are doing in laparoscopy was and is quite different from what you will be doing at the robot. So do that online self-module for the device that you have access to. If you have access to Da Vinci, there is an online Intuitive platform. If you have access to Mantra or Hugo Ras, they have their own online program. So do that. Then come for a hands-on session at dedicated industry training facility. This will give you a console certification, which will tell you that, yes, you have learned about the technology, you have access to the robot, you are able to handle the console. Maybe you are fit enough to operate because you are already a surgical practitioner. And of course, again, I will say at this stage also, take your surgical assistants, scrub nurse, and technicians for a similar training along with you. With this, if we can add a porcine lab or a wet lab, it gives you the feel of the real tissue. Now, I'll tell you why this is required. In robotic surgery, we all know that there is a problem with haptics. The new Da Vinci, the D5, has some force feedback where you can understand the tension between different tissue interfaces. But in the present robot that is there, you don't have haptic feedback. And the instruments can be very strong when you hold. Now, for example, if you're holding the bowel to retract in an endometriosis surgery, you might do it very strongly and actually tear the bowel. So you need to understand how much pressure to apply to hold a live tissue. And for that, I believe the porcine wet lab is an excellent opportunity for you to learn how to do that. Then you can have suturing, you can have dissection practice, and then you can learn how to use your instruments with the correct traction, correct pressure, and correct wristed instruments to be able to do in a live tissue. Aim, again, safe use of robotic equipment, learn the control of the consoles, and learn how to handle emergency procedures. Surgeon-led cadaver programs are also very, very useful to be able to get, again, understanding of how to do dissection and things like that. But if you are a good surgeon, you probably will be able to do that. And of course, then come to credentialing. What are the technical training that you require? So technical training as a surgeon you need, and as a technician in your OT, you need that as well. Setting up, how do you drape the robot? How do you dock the robot? How do you place the patient cart? In which type of surgery? In gynecology, generally we place the patient cart to the side. We don't place either on the head side because that is a space for the anesthetist. Neither do we want to put it between the legs because that's the place where our assistant does a lot of assistance in terms of vaginal manipulation. Of course, then you need to learn how to prevent arm clashes, and some of the instruments or some of the platforms do have this problem. The latest Da Vinci Xi doesn't have so much, but the X may have, or the other platforms may have. So you need to learn that externally your patient's arm, the arm that come to hold your ports, don't clash externally. Because when you're on the console and the arms externally clash, you're not able to do the right movements. Insertion and exchange of instruments, handling of foreign bodies. So you have to also remember that you are away from the patient. So if you have a needle entry exit, you have a gauze piece entry exit, you have anything else that is going in and out of the patient has to be handled by your surgical assistants. So how to handle those foreign bodies safely? Troubleshooting, safely and rapidly remove the patient cart in emergency. What to do if the system stops responding? What to do if instruments malfunction and not respond? So you need to learn all those things while you are in the roadmap and training. And of course, response to anesthesia and massive hemorrhage. So what are the options for surgeons today to learn? You can join fellowships, which are from 6 months to 1 year to 2 years. You can do mini fellowships. You can do mentored skill courses by mentor surgeons. You can have integrated Ob-Gyn residency and DNB programs in hospitals where the robot is already available and surgeons are doing gynecological surgeries. And of course, request integrated into ICOG and FOXY fellowship programs as well. At present, if you want to do long fellowships, then you have 2 one-year fellowships, which are I'm aware of. I'm not sure if could be offered as a hospital basis, but these are known fellowships. One is a Vattikuti fellowship by Vattikuti Foundation, and that's a 1-year fellowship. And then you have Intuitive Fellowship, which is again a 1-year by Intuitive Foundation. You have equivalent certification. That means if you are a good surgeon and you have assisted in to a mentor in about 20-25 cases, both as patient bedside and as console surgeons, then you can get an intuitive certification saying you are an equivalent surgeon and are good to operate. Now there are fellowships or training programs or roadmaps by various associations, of which I will tell in detail about the Association of Gynae Robotic Surgeons of India, which I'm the founder president. And we have started a Indo-European 3-level to 4-level training course for gynecologists who want to get trained. And then you have some international, and we have affiliated both with the European and Asian associations to be able to expand this more. And of course, you also have a FARIS program by an association of robotic and innovative surgeons, which is primarily a surgeon-based organization, but they also take gynecologists if you want to learn. It's again a 1-year to 1.5-year fellowship affiliated to Sri Ram Medical College. And you can have complex benign gynecology course at Orsi Academy, which is in Belgium, in which I'm personally involved with. So let's come to the Association of Gynae Robotic Surgeons, which actually promote learning of robotic surgery for gynecologists by gynecologists to promote this technology to our young surgeons or whoever wants to learn. Now, if you go to our website, you'll find that we have a full details about how to use this training curriculum. We have designed 4 level of courses, and this is an international fellowship because we are training you with the same efforts that the SEARCH or the Society of European Robotic Surgeons do for the last 10 years. So we have joined hands with them. We have a memorandum of understanding with them, and we have to give you a joint certification along with the SEARCH. So the first level that comes is based on a simulator. Now, same as Dr. Mehrotra spoke about. Now, again, we have a simulator which can teach you how to use the console, how to use your masters, how to use your foot pedals. And there are 6 predefined exercises that you have to learn and pass and do. So the level 1 training actually has 3 sets. You first have to sign up and give online, attend lectures and give a test which contains 25 MCQs. Once you do that, then you have a psychomotor training available. We do it on a simulator, not on any of the platforms. And at the moment, it's available at Hyderabad. And then once you do that, you have to give an exam on those 6 exercises, and then you get a certification at the completion. So that's level 1. Let me also bring to you what we are trying to tell you in level 1. There are 5 lectures, which will give you an overview of robotics. Then you do this. This will also give you an idea whether robotics is there for you or not, whether you like to do this surgery or not. And that is where you can actually then progress. So level 1 lectures are usually on evolution of robotic surgery, general principles, role of MIS in gynecology, how does RAS or robotic surgery advantage over conventional laparoscopy, and of course, a view of pelvic anatomy through the robot. This does not authorize you to start practicing as a console surgeon, however. Then we come to level 2. Anybody who has completed level 1 or has a console certification by any of the companies that provide robotic platform in India today can register for level 2. Of course, you have to also become a member of AGRS and surge at special rates. What do we do in level 2? You have to attend these many online lectures first. So we talk about, again, principles of Raj, port placement, positioning, anesthesia consideration, how do you use the energy sources, how do you do an emergency management, and we give you procedural videos on gynecological surgeries, which is benign hysterectomy, cystectomy, myomectomy, radical hysterectomy, sacrocolpopexy, and lymph node dissection. Once we do that, you have to give an online exam and pass. 60% is basic to clear that exam. And once you do that, then you will have a chance to attend any of these centers, 8 centers we have at the moment identified, which are mentor centers, where you can go and attend 10 robotic surgeries. Once you do the 10 robotic surgeries, we also offer you to go for a hands-on wet lab animal training at Enapoy Medical College at Mangalore. This, again, as I said, wet lab is very good and very useful for you to get the feel of the tissues. And then you can do case observation at any of these centers. You can either do all the 10 at one or do 2 at each one. It's your choice. And then when you have done with level 1 and level 2, then we do a level 3, which is a diploma in gynecology robotic surgery. Now, when you have completed level 2 or you're already a robotic surgeon, which has more than 50 cases under your belt, you have to send the association a log of 30 surgeries that you have done in a prescribed format. Then the senior surgeons will look into you, and then we will ask you to send 2 of any of these following surgeries, that is benign hysterectomy, a myomectomy, or a radical malignant hysterectomy with pelvic lymph node dissection, which will be then assessed by an observer from our association, that is AGRS, and an observer from Surge. Once they feel, looking at your unedited video, that yes, you have performed a safe surgery, one of us will come to your theater, will just be an observer, like a proctor, observe how you are performing the surgery, and there is a metrics to mark the surgeon. And then if we find that you are going through all those metrics, you will get a diploma. So advanced training, we can then work on association with the Asian Society of Robotic Gynecology Surgery, which I'm happy to inform that I'm not the president-elect, and next year I'll be taking over as the Asian president for the next 2 years. So we will probably have more programs in association with the Asian Society of Gynae Robotic Surgeons, and of course also in the Europe. So these are the 2 areas we are actually looking at to perform these. So we had this MOU at the Surge, and they have a young European advocates of robotic surgery, where they call mentoring in robotic gynecology surgery. So you can apply for this MERCS program as well if you are a member of AGRS and Surge, and then you will get the option that these are the centers where you can go and then you can observe and learn. So that's an exchange program. The second exchange program that we can do through our association is AGRO, and that's Asian Gynecology Robotic Observation Program, which again we signed an MOU right a month and a half back at Seoul. And then again, there are centers. You can go onto these websites and get into the details and understand how you can apply to AGRO, and then go to any of these centers through the AGRS program, and then go for any of the international observership as well. As I said, Fellowship in Advanced Robotic and Innovative Surgery is part of the ARIS, which is again another robotic surgery group in India. I'm one of the South Zone members for that. You could opt for that as well. The Complex Benign Gynecology course is a program that we focus on procedures, which is both a wet lab as well as suturing technique. And the next dates are 2nd and 4th of October at Belgium, Ghent Academy. This time we are trying to add 3D experience of surgeries as well. So once you do this roadmap or learn, how do you do credentialing? So that's very important. And I think hospitals have different policies, and they should have some strict policies about when to give a surgeon that you are, yes, you are trained, you are now giving privileges or credentialing to operate. Now, a preceptor can give equivalence certificate, or a proctor can sign off on credentialing or give an AGRS diploma. So there are two different ways. Preceptor is somebody who is responsible for the patient. So I'm a preceptor. Somebody comes to my OT or my fellow will operate with me on my patients. I'm responsible for the patient, but I'll say, yes, this particular doctor or this particular fellow is good enough to be having an equivalent certificate. Or a proctor, I can go to your theater, you put your cases up, I do not scrub, you do the surgery, I guide you, and I just let you know at the end of the procedure that do you need more proctorship or you have already done it. So ongoing periodical privileges is also important for us to remain safe surgeon. And it's also told, and it's across the world accepted, that minimum 20 surgeries should be performed by you per year to be able to continue your privileges. And one must do audit of your clinical outcomes for your adverse effects, and of course, the prospective capture of data as case logs. And this can be done by a robotic steering committee in each hospital. Other question of obviously people ask, what is the learning curve? How many cases do I need to learn? Well, that's a very, very difficult question to answer because it's a complex analysis. And I would like you, if you want to know that, please read the systemic review, which is very recently been published. You have to understand how to understand a learning curve substantially depends upon the metrics and the method that I tell. So somebody will say, I'm very good if I do very quickly, but that's not true. Or I do very slow, so I'm still in the learning curve. So that's not true. So the metrics and methods that are employed to assess the learning curve is very important. And the method that we analyze as terminology to use, very good. So this systematic analysis actually used all these various specialities to understand what could be the surgical could be the learning curve. They looked at the metrics. Now, if you look, there are time-related metrics in terms of how much was the operating time, what was the procedural time, how was consult, because everybody talks consult time, docking time, but they're not really that important, and of how much was the setup time. And then length of stay related data, then metric related adverse effect, how many patients went to ICU, how many patients had complications and other regular complications, so on and so forth. They also looked at the number of studies that talked about the operative time. If you look, the maximum studies spoke about operating time, half and half spoke about the length of stay, and roughly all of these talked about the complications. But it is very difficult to put a number that you do so many cases and you are actually past the learning curve. I could be an excellent surgeon, very quick learner. I can pass my learning curve about in 10, 12 cases. But on another half, I can take about 25 cases. So it's a very complex scenario. So don't put a number to yourself. Learn how to do a safe surgery, and that's what is important. So a surgeon's previous experience becomes a significant factor. And of course, the procedure complexity, what type, if you do a simple hysterectomy, which in the lab also you were doing in half an hour and you do in half an hour, well, that doesn't matter. But if you do a stage 4 endometriosis safely, maybe you took 10 minutes extra, that could be a more important criteria to understand your learning curve. So when you look at the surgeons, there is a learning phase, then there's a competency, proficiency, and then there's a mastery. So all of us should aim to reach that number 4 and the mastery stage where we can actually really master the robotic technology and the robotic way to operate to give our patients effective and safe surgery. I thank you all for giving me this time. Really something very, very close to my heart. And any questions I would love to answer. Anybody can write to me, ask me, call me, and we'll be there to help. Thank you so much.
Yeah, thank you, madam. Just a quick question. You know, I think those robotic, how do you say, the training procedures were similar to GISE. I don't know if you're aware of the European.
Yes.
Yeah, it's very similar, where you send us a few samples of cases you've done.
Yes.
They evaluated by some experts.
Yeah. So GISA is basically based for laparoscopy.
Yeah.
The Surge actually took the same concept and developed the robotic program.
Yeah.
And that's what we are also trying to do, because we felt this was probably the best way to start the whole thing at the moment in India.
Yeah, but
So
if you need to...
Yeah, go ahead. Go ahead, Gaurav.
Hello. Thank you, Dr. Ruma, for the excellent talk. And I think she's been the pioneer in starting in all these courses of credentialing, starting the whole organization. It's a fantastic and commendable job Dr. Sinha has done in our country. And, if I may add as to, is it important to learn robotic surgery for that matter? So if you're a good laparoscopic surgeon, there is perhaps little need to learn the whole thing. If you are comfortable doing your surgeries laparoscopically, which a lot of surgeons in our country are, it's absolutely fine. Robotic surgery is, for people who really want to take things further in terms of getting the accuracy. If you feel confident in laparoscopy, there's absolutely no need to, just push yourself into it. But robotic surgery, the vision is absolutely unmatched during the whole process, and the kind of dexterity and movements and the complexity of surgeries, which perhaps an average surgeon can do, is just, phenomenal. And a lot of youngsters, they're starting to pick up on robotic surgery, and a lot of our fellows, when we see them do, it's much easier for us to let them do robotic surgery rather than laparoscopic, because the chances of any errors is minimized by the great vision that we get during the surgery and the ease of surgery.
Thanks, Kanika.
I think
another quick question. What is the weightage do you give to all these types of certifications or courses or fellowships in as far as medical legal significance? Is there some sort of minimum requirement or?
See, as far as we are concerned, it's an association-based certification, right? So you can just extrapolate to what is the medical legal go of an, say, FOXY endoscopic training of 15 days.
Yeah.
Told in the court of law.
Yeah.
Okay. So right now, best would be to have this integrated in the DNB and MD program. But we don't have that. So we need to have, before we started all this, how were we doing robotic surgery? You would have a console training by the industry, and you just sit on the console and operate. That's how we started 12 years back, right?
Yeah.
So this is an attempt to do a little bit more organized way, take them stepwise to understand. And I hope that because it's through a agnostic association and not through any company or any one particular hospital, it should hold in a court of law. We have not tested it, so I don't know. But I am hoping that just because most associations certification programs do have some value, this should also have the value.
Yeah, because right now, the reason I asked is because right now there's a range of robotic surgeons in our country. Some of them have just done an observership.
Yes.
Some of them who may not have done a fellowship. I mean, there's a range. So there's no, I mean.
Yeah, so actually, I still feel that the young surgeons who are just passed out of their MD or DNB should do at least 6 months to 1 year fellowship.
Yeah.
A practicing surgeon, it's very difficult. Like for you, if I ask you to come for 6 months, it's difficult, right? Yeah. And you know your surgery. So all you need to know is the platform. So we need to devise something where you will be able to understand the technology to be able to extrapolate or do your surgery, which you already know. But I still feel, and I'm very, very vehement about it, and I tell all the juniors or fresh pass outs who come, they all call me, is there any observership? Can I come for 1 week? Can I come for 10 days? I said, you can come for any days and stand in my operating room, but I don't think that will certify you to operate.
Yeah.
Yeah. So I think we have to be careful about that.
Yeah.
We should not be asking people to come for 10 days in my theater and give them a certificate saying, I certify you to be doing that. I think, and that is the reason why as an association, we are trying to move so that because this is well deliberated, there is a group of people, we talk what should be the minimum criteria, what should the student learn, what they should do online learning modules to be able to get some semblance of what is robotic surgery.
No, because I can speak for the Vattikuti Fellowship where it was a mentor-mentee, which I was a fellow.
Yes.
And there are, of course, simulation models on the DaVinci Xi itself.
Yes.
So, I had to go through all of that and be assessed. There's a lot of learning curve that goes through it.
Yes.
Thank you. Thank you, Dr. Ruma, madam. It was wonderful, excellent. And it was really a guidelines for all those youngsters who want to take up all these technologies in future. So thank you so much. And thank you both the chairpersons for sharing the
Pratibha,
session.
just 1 minute. Ruma,
yes.
It was an excellent presentation and we are really proud to see you that you've reached to this level and you're doing excellent work. So keep on teaching more and more people and really proud of you.
Thanks, Parag. I remember the good old days.
Yes.
Yes.
Vaishali Achhi?
Yes, it's
So,
all right.
so we have Dr. Parag, who is the chair ICOG elect. So, sir, you want to say something more?
No, I have
Dr.
already
Parag?
said. I think
Yeah.
we would ask Dr. Sanjay Gupta to comment about the medical legality.
Sir.
Sir is the pioneer of
Yes.
education on medical legal. So, sir, your
Yeah,
comments
sir can
on
give me
the
some advice.
Gaurav's question.
Yeah.
Two things. First of all, Ruma, fantastic lecture.
Parag, let me add something on
Really
the issue of
motivating.
cost efficacy. When patient asks us about this aspect, what would be our answer?
Right. So the thing is ki the way you are going about it is perfectly correct. And in any court of law, when somebody has gone through all this learning, it will be having a huge weightage. And I don't think your fellows or whoever is trained this way have to worry about medical legalities at all.
Thank you. I think thanks. It's great coming from you, Dr. Gupta. In fact, when Gaurav asked, and this has been actually in the back of our mind also, that we should not be in a rush to give certification to people who are not, although we know that, I mean, Gaurav will also know that there are many hospitals where there is hard, I mean, surgeons are on the console without much training as well. So that is something which, but you can't, I mean, you can just show a path. You can't really control everybody, right? But I think, thanks, Dr. Gupta, if you are saying that, we will try our best through the association to make a agnostic as much as possible. What we feel that the surgeon should learn, because we have learned very hard way. When I started 12 years back, there wasn't anything of this. Bit by bit we learned, and at every step I felt, okay, if this was there, it could have helped me or made me better. So I'm just putting all those experiences in this association and trying to put these things that if there was somebody to guide me wrong back, how it had been done. So and as I said, it's a group of people, it's an association, so we are all trying to do our best.
Fantastic.
Fantastic, sir.
Thanks.
Ruma, I
thank
did
you.
ask that. Sir, hello.
Yes.
Am I audible? No, I asked you, what would be our honest response when patient asks for cost efficacy? Whether she is getting something really additional by opting for a higher price technology. Because these questions are posed to us many times. Does this surgery require a robot? Would it enhance the quality of care? Whether the additional cost is worth its while or not?
You're asking me or sir?
So,
sir, okay.
All
of you.
So the thing is, if the surgery is going to enhance the actual this effect of the surgery itself, or the effectivity of what's going to happen, then the cost doesn't matter. Now somebody can always say that, no, I'll do equally well with maybe 3D laparoscopy and all that. There are people I know who would say that, but it depends on what, because this is an advanced technology. Again, if you have somebody who has not properly learned and doing this, then we'll be actually doing damage. So it depends on the surgeon, the ethics of the surgeon, the skills of the surgeon also, and then the surgeon himself or herself should feel that I'm doing justice by doing this surgery, because I'm doing something additional, something safer, and so that makes it ethical.
Let me put this way, Parul. I do agree even now that this technology should be deployed responsibly. Okay, let me clarify what I'm trying to say. I don't believe that today we should be doing this for very simple cases. Definitely not. Neither am I able to justify, nor anybody in this country will be able to justify, because the resource is limited, it is expensive. It's a different matter that 8 or 10 years later, you will find this computer-assisted surgery, some form or the other, in all theater, just like we find laparoscopy today. It is definitely an advanced form of surgery. It is definitely more precise surgery. But yes, when the cost is there, we need to justify. So a complex surgery, or surgery which that particular surgeon feels that I may have to maybe, intra-op convert into open. So if I say, okay, this is a difficult surgery for me, and I may be different from you or from somebody else, and I say, okay, this is a very large or grade 4 endometriosis, I start doing, there's a 10% chance I may convert. But with this technology, I may not be able to convert. So I'm giving a benefit to the patient that way. But I still feel that it will be futile if I'm trying to do very small cases or something which can be done laparoscopy, but like for surgeons like you and me, probably not justified at the moment. I do believe, but you cannot be not embracing a technology. It is here to stay, whether we like it or not.
No, I'm not denying. I'm of course all for integration of technology. The question which I posed to you was because I was attending a conference, SLS meeting in Hawaii, where they brought out these issues that in US there were 5,000 robots at that point of time. In China, there were 3,000 robots. At that time, India had only 100. Today, I do not know the figure. This was about 4 years back, before the corona. So the question was that in US, all the youngsters were bypassing the conventional laparoscopy because this was easy to adopt. And then the hospitals which were buying robots were indirectly sort of encouraging youngsters to use it more and more, which I have seen even in Ahmedabad today, that those hospitals who have installed robot, they indirectly, not officially, try to encourage that recruit more patients to use the robot. Of course, it is all everywhere, finances are important and those pressures are there. But then for us as doctors, that ethical issues come up, that what should be our response to this situation?
Yeah. I think it's
or then ultimately it will go to individual ethics, but I do not know as a body should we have some guidelines, because I think the American Gynec Association, ACOG, had those guidelines some time back that it should be reserved for certain types of cases.
No, but you know, then there is the other thing that some patients might come saying that I want a robot on demand. It might be a simple pathology, but the patient insists that it's like a C-section on demand.
I know, I fully agree. The same thing happens to so many things. Patient wants IVF directly, nothing in between. But then what we should do, I mean, that is what I am asking.
So finally, ethics is, your own soul, actually a surgeon's soul. And
Absolutely.
you have to decide.
Yeah.
Absolutely.
Patient demand, is it okay?
Parul, I totally agree with Dr. Gupte. Ethics is your conscience and everything. Now, if you will put a guideline that in
like most responsible bodies have said that on demand cesarean should be applicated.
I mean, if you
Sorry?
said, I mean,
Sorry.
for this, don't do hysterectomy, you'll find so many of them doing. So it's a personal ethic, actually.
No. See, in general, what demand cesarean, most responsible bodies are saying that it is not a sort of an appropriate thing, in spite of patient asking for it. That kind of a thing, can we do it? That certain types of cases, even if it is on demand, you explain in detail everything, and then if patient decides, it may be a different thing. But well, I'm just putting across a thought. Let us all mull over it, and then maybe some other time we will discuss this.
I think comparing cesarean to this is a wrong comparison. Is a wrong comparison.
Exactly.
Because by doing cesarean where it was not needed, you probably will harm the patient. Like not harm, but it was an unnecessary thing. And here, all you have done is you have done a good, safe surgery, except that it was more expensive at the moment. That's all. I think there is no other argument in the whole thing.
Correct. Yeah.
So we have to just wait and watch how this cost comes down. It's already coming down. And once, and believe me, the cost, actually, when you're talking about US and those robots, I from what my understanding is, there is no separate billing for robot in US. The hospitals absorb the cost in a different manner. The doctors, I think remuneration is also the same, either you do lap or robot. And that is why people who know how to do robot and can do fast and more efficient surgery in the same day. They can do many more because it's more intuitive and more easy to do. And that's why the younger ones, why should they have a long learning curve of 10 years like you and I had? Faster, and they do good work. So I think it all boils down to cost. Cost is coming down. It will come down more. And that is cost is the only reason for discussion at the moment. Nothing more, I think.
Ruma, I had one question, one perspective, that there has been some studies on evaluating the clinical outcomes from route of hysterectomy. And, this study was few years back. I think it was 2015, the evaluate study, for TAH and vaginal hysterectomy and laparoscopic hysterectomy. So in that, this vaginal route came out as the winner. They said that it is the least invasive. It's not only minimally invasive. So probably we are looking at something coming out from, robotic as a comparison for clinical outcome also. It's not just the cost now. The clinical outcome also, probably you would say that it is kind of very, very good. But then the thing is, when clinical outcomes are similar, then why not offer the least invasive first? Right, that is what. So then there are.
Okay, I'll tell you something on this.
I'll just complete in another 30 seconds, because we all look up to Shirish sir as, a very, very great champion of vaginal. We have been following him for decades. Now, I have heard him say, and other proponents of vaginal surgery say, that every uterus which can be removed, this is only about hysterectomy I'm saying, of course, nothing else we are considering now. So whenever a uterus can be removed vaginally, should be done so. And, we have been teaching that to the postgraduates, to our next generation for a very long time now. And we have been practicing that also. Probably teaching institutions will be following this path. If I'm not wrong, if there are any professors from medical colleges, because we have to, I think we have to promote vaginal hysterectomy as compared to the other routes of surgery. And I do have a task of holding back my staff from doing TLH in cases where they can do it vaginally. I always want them to do it vaginally and teach the postgraduates the art of vaginal surgery. So everything else, I think the myomectomy and the endometriosis surgery, etc. Of course, the laparoscopy and robotic will always remain as the primary choice. But for hysterectomy, I thought I'll just put this perspective. Thank you for the time. Sarita, Paru, thank you for the time. Yeah.
Shobha, your point is excellent. And I think I will also tell you this, I'm probably also one of the person addicted to non-distant vaginal hysterectomy. Given a choice, I still do it. But the problem in our practice now has become is that the cases we were doing NDVH no longer require a hysterectomy. We manage them medically. The cases that come today for hysterectomy or any gynae surgeries are more complex. There are either multiple myomas or stage 4 endometriosis or previous multiple surgeries, black additions. In that, an average surgeon, it's difficult to do vaginal surgery. That is the challenge. We should teach our postgraduates vaginal surgery because I think that is excellent. Aaj ke tarikh pe bhi agar kar sakte hain, to I think all of us, there is no harm in doing it. We should do it. Agreed. But the cases have become, there's a shift in the paradigm of the kind of surgeries we are doing for gynecology. So many, somebody in the beginning, I think, spoke about medical management. Marina is a great leveler. I think 50% of patients on mine go home with Marina and no need for hysterectomy.
Yeah, that is very true.
Yeah, that is true. So we are not doing hysterectomy for those cases where NDVH was, 30-minute case, which was at one time so well done. So
actually, LNG IUS has become a topic of discussion in OT committee reviews. They're asking us, why are you no longer operating for?
Well,
so
that's
we are telling them that we are not able to do hysterectomy because they're improving with this.
Yes, that's the ethics we are working on.
Yeah.
Excellent, Dr. Ruma and Dr. Shobha. It was good. Yeah, we say that vaginal surgery is the signature of gynecology. That is what we have been told. But anyway, the type of surgeries which you are doing and do the robotic, that is all advanced cases. And for that, you should be given that option. So wonderful talk, Dr. Ruma. And thank you so much for enlightening us. And with this, we'll move on to our next session. And I can see Dr. Alpesh Gandhi, sir, for that. And to chair that session, we have respected Dr. Sanjay Gupta, sir, and Dr. Archana Kumari. So can I have the CV of Sanjay Gupta, sir? And he is... hello, can I have...
Pratibha ji, you can skip it,
Yeah,
let's
he's the
save
past
time.
president, Foxy, and a very versatile personality, and always there for us. So, Sanjay
skip
sir,
that and
thank you
let's
so
save
much
some
for
time.
joining, and welcome to this
Sure.
forum today. And our next chairperson is Dr. Archana Kumari. Can I have her CV? Dr. Archana, she is the professor in Ranchi Medical College, RIMS, and at present she is the secretary of Ranchi Ob-Gyn Society. And so with this, I'll request Dr. Archana Kumari to kindly introduce our speaker, Dr. Alpesh Gandhi, sir.
Yeah, good evening, everyone. First of all, I must acknowledge and offer my regards to ICOG office bearers, Dr. Parul sir, Dr. Sheila Bhane ma'am, Dr. Sarita Bhalara ma'am, Dr. Parag Binewala. My pranam and regards to Sonawala sir and Sanjay Gupta sir. It is indeed an honor to introduce a personality like Dr. Alpesh Gandhi sir, the past president of Foxy. Sir has done tremendous work during his presidential year.
Dr. Archana Kumari.
Yes, sir.
And I request you already introduced me as a past president. I think it's enough.
No, sir. Sir, I must acknowledge the kind of work you did during your presidential year, establishing so many HDU and ICU in district hospital, partnership with Foxy with UNICEF to mentor Lakshya Quality Improvement Program in so many district hospital. And for this program, I was closely associated with you. And of course, to formally introduce him, he has been the vice president also in Foxy 2013, governing council member of ICOG, chairperson practical obstetric committee. Sir was the national coordinator of emergency obstetric care program of GOI and Foxy, member of PCPNDT Act implementation and supervisory body. And of course, he has edited so many books. One of his books is very famous for postgraduate for Foxy textbook. And I had the opportunity of writing a chapter. Thank you so much, sir, for this opportunity. And sir is always keen on promoting young generation and smaller societies. Thank you, sir. And with this, I invite you for a talk on AI innovation and Ob-Gyn.
Dr. Alpesh has been, during COVID time, he promoted the Foxy activity like never before. And he's the father of these webinars that all of us are doing, actually. He started all these platforms, so we must thank him for that.
Yes. Yes, sir.
Yes, sir.
Thank you, Archana Kumari, and thank you, Dr. Sanjay Gupta, sir, for the kind introduction. After a very two interesting talks by Dr. Narendra and Dr. Romasya, and a very electrifying interaction, very interesting interaction, I'm going to speak on a topic, basic of AI and its few possible applications in obstetrics and gynecology, how it can be a transforming obstetrics and gynecology practice. I'm going to speak on a relatively new topic which has generated a lots of interest recently. At the same time, not much explored by majority of us in our routine day-to-day practice. And at the same time, it is not easily available at present in India, but it's a big promise to our future practice. Let me accept at the beginning that I have not much experience of AI, but I am impressed with its possible applications. And at the same time, we all have little experience of its benefits, like calculator. Calculator is multiplying a big digits in a second, for which we may take many minutes. So many things are that in our routine practice. Suppose we are taking all the parameters, BPD, head circumference on femoral length, everything, abdominal girth. But then our machine can plot everything on the graph, and it can predict percentile, and from which easily we can predict FGR. So similarly, this is a machine which is working intelligently, and I would like to discuss a brief about its concept and its possible applications. So at the beginning, I think we all should understand what is the difference between machine intelligence and human intelligence. Human intelligence is general intelligence, that is cognitive learning, problem solving, etc. Plus biological intelligence, that is consciousness, emotions, and many more. So this is human has both the intelligence, general intelligence as well as biological intelligence. Whereas a machine with AI does not possess the biological intelligence expressed by humans and animals. So this is the difference between machine intelligence and human intelligence. So artificial intelligence in its broadest sense is intelligence exhibited by machines, particularly computer system installed in the machine, inside the machine. So it's a field of research in computer science that develops and studies methods and software that enable machines to perceive their environment and use learning and intelligence to take actions that maximize their chances of achieving defined goals. Such machines can be called AIs. If we look at the history of AI, then word AI was coined by John McCarthy and Marvin Minsky in 1956. So it is not a very fresh or very new word or new technology. AI came into public focus in 1997 when a very famous world champion, chess champion Garry Kasparov was defeated by IBM's Blue computer in chess using AI. So since 1997, it is more in discussion. And a futurist, Martin Ford, asked 23 leading experts in 2018, when will machine achieve all different type of general intelligence? And the average answer was in 2099. So, and how AI works? Then it works by artificial neuron network. An artificial neuron network is a computation model inspired by the structure and function of the biological neural network in animal brain. It consists of interconnected nodes, which can be known as neurons, that process informations. Each neuron receives signals from connected neurons, process them using an activation function, and send output signals to other connected neurons. These networks can learn from experience and derive conclusion from the complex data. They are used for tasks like predictive modeling, adaptive control, solving problems, and others in AI. And that can be assessed by programs like Google, TensorFlow Google, and Facebook is using InFlyTorch. So similarly, all these big sorts are using AI in their programs. So looking to its different applications of AI, automated reasoning is one, knowledge representative having a dialogue in natural language is another. Automated planning means autonomous robots and unmanned vehicle. We all are now knowing about the vehicles, driving a vehicle without a driver. So now it is possible, and we all have witnessed that at certain places, this type of vehicles are there where driver is not there and even the vehicle is running. Machine ability to move and manipulate objects. Now, recently I was in South Korea and in Busan for the AO4 conference, and there in one of the restaurant, robot was moving to collect all the used dishes. So this is machine ability. Natural language processing. Suppose we are in France and there is some instruction in French which we could not understand, and then if we go on Google for this translator, and from Google will translate this language into English, and from this we can come to know what is what is this instruction in French is. So this is, we can say, natural language processing, machine perception like vision, touch, afflection, hearing. So machine learning is study of computer algorithms that improve automatically with experiences. So machine learning is a very, very new, we can say, emerging branch in computer science, and machine learning is a subfield of AI in which a machine can learn and adapt to situations and data training that uses algorithms trained on data sets to create models. And these models enable machines to perform tasks that would otherwise only possible for humans. Machine learning learns from examples, from data, and adapts autonomously. It is like teaching a computer to learn by showing it many examples of a specific task. And this is known as machine learning. And this machine learning is basically used for AI. So AI has valuable in routine work across various domains. Now it is used in not only on healthcare sector, but in so many other sectors for automating repetitive tasks, data analyzing and insights. Particularly in healthcare, AI helps diagnose diseases from the medical data and images, predicts outcomes, and recommend personalized treatment. Language, natural language processing, it powers virtual assistants, language translation, sentiment analysis, content summarization. So it enables machines to understand and generate human languages. Very important role, predictive analysis, analytics. Business uses this for demand forecasting, fraud detection, personalized recommendation. Many of us are using Netflix, and now Netflix, because it has follow our interest, and from these Netflix may suggest us coming shows which are of our interest. So this is predictive analytics, process optimization. It optimizing supply chains, logistic, manufacturing processes. It minimizes waste and also reduces cost and improves efficacies. Personalization again is a very, very important use of AI application. AI tailors experiences to individual preferences. Think of personalized ads, products recommendation, and social media content. Healthcare, it aids in diagnosis diseases, drug discovery, research, in predicting outbreaks. It also assists in surgery, I've just discussed robotic surgery, and monitor patient health. So many in healthcare, we can say in near future, it is going to bring revolution in our healthcare by use various applications of AI. Again, frequent use in finance, AI algorithms analysis, stock market trends, and can manage individual portfolios also. Energy efficacy, it optimizes energy consumption in smart grids and buildings. And of course, it provides various learning platforms and important personalized education content for students also. And just discuss now, we do not need a library, and many things are already there on AI and Google. So similarly, it has role in all the various domains, but we are interested in particularly in transforming healthcare in numerous ways, how it will affect. Some key roles of AI plays in healthcare. Early detection of diseases is very, very important. Then diagnostic accuracy. AI algorithms analyze images, X-ray images, sonography images, CT scan, MRI images. It can collect, it can also uses analyzes data like blood reports and often other data also with very high accuracy. So from this, it can diagnostic accuracy can be there. A personalized treatment plan. It analyzes patient data, genetic data, medical history, and all this laboratory data, imaging data, and to develop personalized treatment plans. And it can suggest which plan may be better for this patient. Predicting analytics, AI model predicts possibility of readmissions, possibility of patient outcome prognosis. It can also identify at-risk patients for proactive care. So many predictive analytics can be possible with this AI. Robotic surgeries, AI-powered robots and surgeons in performing surgeries more precisely and accurately, which will save complications and time. So all these are the possible key roles of AI in healthcare. Virtual health assistant in chatbots. AI given chatbots are now frequently used, can provide initial assessments, answer queries, and guide them for appropriate care, mainly in chronic conditions. Now, patients can go to the chatbots and can get knowledge and information and can solve their queries about the we can say how to control family planning measures and many other things like chronic disorder conditions like like diabetes mellitus, hypertension. So all how to manage, how to monitor, many things they can come to know from these chatbots. Drug discovery and development, it accelerates the process of research by analyzing large database, reduces cost and time in bringing new drugs to the market. So it can be helpful in research of the drugs. Public health management, by analyzing public health data to monitor and predict the spread of infectious diseases. Just we all are the witness of COVID-19. So it can be helpful in knowing in how much time and in which areas the infection will be spreaded and what to do to prevent this infection. Then improving patient outcome. It facilitates timely interventions, improving patient's outcome and quality of life. Of course, it has a significant role in hospital administration and efficacy. Automates hospital administrations like maintaining records, scheduling appointments, billing, etc. So many aspects. Even from staff recruitment, it can be helpful in so many aspects. AI can be there, useful. Particularly in clinical obstetric and gynecology, AI applications can be helpful in obstetric. It can identify and predictive because with its predictive analytics for high risk pregnancy, it can identify and predict high risk pregnancy possibility of, and then risk stratification for gestational diabetes mellitus, preeclampsia, preterm labor. AI can be useful in obstetric and gynecology, ultrasound analysis, in labor and delivery, in postpartum care, in infertility, in gynecology, AI in gynecology cancer, AI in precision medicine, and AI in hospital administration. So AI can be helpful in our clinical obstetric gynecology and management of our hospital by its different applications apps. Combining AI with obstetric ultrasound can optimize fetal examination. AI assisting in automating measurements and identifying anomalies, reducing time needed for each scan. Just I informed that I was at Busan city for AOFOG conference, South Korea, and where I got an opportunity to meet senior engineer from Samsung, and he has shown that within 1 minute he already examined the patient and then ask the patient to go to her home and the report will be sent on her mobile. So just he told that within 1 minute this is possible. All the images are already taken, already stored, and then it will automatically, this machine will calculate, measure everything and will prepare a report which will be sent to doctor on doctor's mobile and patient's mobile. So it's shorter examination time. At present, if we want to thoroughly examine a patient, obstetric sonography may take 15, 20, or sometimes if fetal position is not good, it may even take 30 minutes, or sometimes we may have to ask our patient to come again for fetal sonography. So this can be, we can help such patients, and it will definitely shorten the examination times. It can examine within few minutes. It can also be benefited from AI's ability to analyze imaging and provide preliminary assessment, and this will easing our workload. It will also enhance diagnostic accuracy and improve overall accuracy. It may be helpful in detection of fetal diseases, like AI techniques aid in identifying complex fetal conditions like FGR, congenital diaphragmatic hernia, amniotic band syndrome, gastroenteritis, etc. So sonography machine with AI are already available. Some of the companies are already in the market, came out with this facility, but still more and more thing will be done in AI in obstetric sonography. This is example, automatic mid-sagittal plane selection by AI, and then automatic segmentation of the knuckle membrane and the edge of the soft tissue overlying the cervical spine, and then the automatic calculates the minimum vertical distance between the two lines and computes the largest as the anti-measurement. So we have not to do much work, and this our work will be very much easy with this AI. And not only work will be easy, the data, the finding will be also the more and more accurate with the use of AI. Otherwise, at present, it depends on our experience, our skill, our time. So many things are there for obstetric sonography. It has specific role in obstetrics, particularly early detection. AI algorithms analyzes to identify patterns associated with pregnancy complications like fetal hypoxia. Sometimes it is very difficult and to identify fetal hypoxia, but with the use of AI, we may be more clear about the possibility of fetal hypoxia. It allows timely intervention. Sometimes we may be late in identifying fetal hypoxia, but with AI, it may allow timely intervention and improved patient outcomes. Personalized treatment plans by considering patient history, medical data, AI tailors personal treatment plans. AI model predicts risk related to high risk, mortality, fetal problems, and birth outcome. AI tools aid in interpreting fetal heart rate and cardiotocography to detect fetal distress and other complications. And now there so many devices, medical devices are available for this fetal heart rate monitoring, and it has now become very simple and very accurate with this AI interpreting fetal heart rate. AI algorithms has tapped into enhance fetal heart rate monitoring. It helps filter out noise from fetal heart signal and improves accuracy by noise suppression. AI identifies relevant features that indicate fetal health, and AI identifies and classifies fetal states, whether it's a normal fetus, compromised fetus, or distressed fetus, more efficiently than traditional methods, because there are certain requirement in traditional methods like experience, skill, time, cost, so many things are there. So AI can identify and classify fetal states also. And this is again for a role of AI in fetal monitoring and interpretation. AI algorithms can analyze the fetal heart rate patterns during labor more efficiently and help identifying signs of distress, which can allow timely intervention. And this is a simple device which can be applied on mother's abdomen, and we do not need to identify where is the fetal heart. It just apply over mother's abdomen, and there is also no need of straps. So patient will also be comfortable. Patient can be ambulatory, and this will send the signal to the tab or computer, and from this we can easily come to know many information about the fetus. We can predict fetal distress, a very simple device and also not costly. So many things now. Fetal ECG machine device is also there. Device is also there. So many things are there for fetal monitoring and interpretation. It will be possible with the use of AI. Labor assessment, progress assessment, AI can assess partogram, cervical dilatation, fetal descent, uterine contraction, labor progress. It can predict the livelihood of successful vaginal delivery, helps clinician to decide when to intervene and allow more time for natural delivery. AI can predict the need for cesarean section by considering various maternal fetal factors and labor progress. This assists clinicians in making informed decisions, and probably patient may also may convince with this decision support of cesarean section from AI, and it may be also be helpful in avoiding unnecessary surgeries also. AI model assess maternal fetal risk factor during labor, for instance, preterm labor prediction, and automatic routine tasks like test result analysis. AI can process laboratory results quickly and can alert clinicians to abnormal values, and can alert clinicians from these abnormal values that this patient may likely to develop DI complications like DIC. So automatic routine task from various test results, it can predict certain things which can be very much helpful. It can alert clinicians about the abnormal values. AI tailors recommendation based on an individual patient profiles. For example, labor induction timing. AI suggests optimal timing for labor induction from all this data. Pain relief option. AI considers patient's preferences and medical history and can suggest a better option for the pain relief. AI analyzes real-time data during labor to predict PPH, and it can also calculate shock index, which is very, very important because from shock index we can come to know so many things, and which can alert clinicians for the early intervention and prompt intervention. Monitoring maternal vital signs, of course, AI can continuously tracking maternal pulse, BP, respiratory rate, oxygen level. Alerts are generated if any parameters deviate from the normal, and from this also it can alert clinicians, and it can be helpful in assisting anesthesia management also about the optimal epidural dosage based on patient characteristic, improving pain management, so many other things. It can be helpful to anesthesia. Also, AI to identify, of course, it has significant role for reproductive medicine, can be useful in identify anomaly, uterine anomaly, pathologies, particularly endometrial problems, assessment, evaluation of endometrium. It can be helpful in automatic assessment of AFC, follicular count, follicular tracking, dose calculating of gonadotropin, AI to automate endometrial receptivity analysis, color Doppler study. We can feed all this data. AI used for ovulation prediction can suggest accurate time for the time intercourse, natural cycle frozen embryo transfer using serial estrogen, progesterone, LH level. So many things AI can be helpful even in reproductive medicine. And now there is a vast usage already started across the world for this reproductive medicine. It can be helpful in embryo selection. It can be helpful in sperm assessment. It can analyze sperm morphology, motility, DNA fragmentation, can assist in sperm assessment for quality, sperm quality for ICSI, image analysis, classification. Personalized treatment plan can be tailored based on couples' clinical findings, profile, laboratory, and other test reports. And it can also predict about the ART failure, likelihood of successful pregnancy or live birth rate. So it has many roles in infertility and even in gynec cancers. Medical image recognition from diagnostic imaging, and it can be helpful. AI algorithm can excel in analyzing medical images, including mammogram, ultrasound, MRIs, and can assist in early detection by identifying subtle abnormalities or patterns associated with gynecological malignancies. AI aids pathologists in analyzing tissue slides, improving accuracy and efficiency in diagnosis cervical, ovarian, and endometrial cancers. AI models can predict disease progression, particularly prediction of ovarian cancer, survival, endometrial cancer assessment, so many things. And even it can help identifying novel targets and optimizing existing therapy for drug research and development. And again, it can be helpful in treatment personalization. For instance, it can recommend optimal chemotherapy regimes or targeted therapies for ovarian or cervical cancer based on patient-specific characteristic and genetic profiles. It can also assist radiation oncologists in planning precise treatment delivery, minimizing damage to healthy tissues, because it is always we are worrying that because of this chemotherapy or because of this radiation, other normal tissues are damaged or not. It optimizes dose distribution for cervical and endometrial cancer. And survival prediction and prognosis can AI models analysis clinical genomic imaging data to predict patient outcome also. Of course, it can be helpful in workflow optimization. So AI holds immense potential in gynecological cancer care also. So it has a significant role in various aspects of obstetric and gynecology. And this is a schematic diagram of application of AI in gynecological malignant tumors, how from shallow learning, deep learning, and then ensemble a classifier, then it can be applied, AI can be applied for this diagnosis of from imaging, pathology, and serology. and can be helpful in treatment like drug research, chemotherapy, and clinical decision support system, and then about surgical method, and then for the prognosis like recurrence, survival rate, everything. So this is a schematic diagram how AI can be helpful in gynecology, malignant tumors, and at many places in cancer institutes now they have started using AI in the different applications. Of course, in hospital administration, like it maintains electronic medical records. It can be helpful in work distribution in hospital, laboratory, and laboratory, resulting in better work efficiency. It can manage stock keeping and inventory. It can also keeping data of expiry and replenishment of medicines, renewal of licenses. It will remind us that now this is the time, this expiry date is over. Now you have to renew this license. So we are this will bring safety to our practice. So it can be helpful of data analysis from which we can come to know about the HMI system. We can say conducting cost-effective research using AI and minimizing patient stress and increasing clinical efficiency. So AI can be helpful even in the hospital management and administration. And one of the survey conducted recently in USA about the in doctors about the survey about its utility, and 53% of the doctors were optimistic about the prospects of AI in medicine. 35% already started using AI in their practice. 66% believe that AI will lead to faster diagnosis, and 66% believe that AI will lead to more accurate diagnosis. And this is just few things, few aspects were evaluated, and this is when so much awareness is not there, much applications are not there, much machines are not there, and at the same time it may be costly. So in future, when all these things will be there, machines will be there, awareness will be there, cost will reduce. At that time, I think with more and more awareness, more and more use, there will be more and more use of AI in our healthcare sector. Of course, there are so many challenges. Despite progress, challenges remain. About data quality, AI models require high quality data for training. Interpretability, understanding AI decisions is very essential for clinical acceptance. It requires clinical validation. Clinical validation of AI model remains crucial. So any progress may be there, but if clinical validation is not there, then it will be useless. Many AI applications may remain experimental without robust clinical validation. So it is very, very important. It also needs to ensure transparency and ethical use of AI, and AI should be unbiased. So ultimately, this all depends on the data quality and which we are feed in this AI machine, and the model which we are preparing. It should ensure equitable access to AI-driven care. There should be a collaborative efforts between clinicians, researchers, and AI experts, which is very, very essential. Otherwise, our expectation may be something different, and we may have some different type of application which we may not like to use in our practice. So collaborative efforts between clinicians, researchers, and AI experts are essential. Integrating AI seamlessly into clinical practice and within existing health system is also important. An expansion of AI applications to low resource setting and rural setting is also very, very important. Still needs to be more humanized. We cannot be so much machine minded, and still AI needs to be more humanized and needs to further protect patients' privacy, patient safety, and patients' health. Further improve according to local ethnic conditions, which should also be considered, is very, very important. Local ethnic conditions and national conditions should be considered, and there should be a possibility of further improvement according to the local conditions. Of course, there is always a question about what is legal validation, what is insurance protection for its use in healthcare. Is it at present? Will insurance companies consider this? Will they provide charges and will they believe the report of AI? Will there is a legal validation? All these are at present a challenge. I think in future this all will be settled down, handled. So in conclusion, ethical regulatory consideration, it's crucial to ensure AI system in transparent, interpretable, and unbiased. Ethical use of AI involves balancing automation with human oversight, judgment, and maintaining privacy of our patients. AI is not a technological advancement only. It's a catalyst for a more efficient, effective, and patient-centered healthcare system. As AI continues to evolve, its integration into healthcare will likely bring more innovative solutions to improve patients' care and healthcare outcome. AI is not here to replace clinicians. There is always a fear, but I think AI is not here to replace clinician. It should be very clear. Previously, sonography machines were not there. Now we all are having sonography machines in our hospitals. So it's a powerful tool to enhance their capabilities. Important thing is its proper use and it should not be misused. As technology evolves, we will continue to find innovative ways and refine those tools to improve for maternal and fetal surveillance and outcome, improve outcome for couples seeking infertility treatments. As research progresses, collaborative efforts and adherence to standards will be crucial for successful implementation and further development. Deep learning will have a profound influence on the future of medical technology. AI complements human expertise. The obstetric and gynec remains a place where compassionate care and clinical judgment go hand in hand, and clinicians should retain ultimate decision-making authority in spite of the era of AI. Once Stephen Hawking has declared that about the danger of AI. AI will spell end of human. Once human develops AI, AI will take off on its own and redesign itself at an ever increasing rate. Humans who are limited by slow biological evolution will be unable to compete with the pace of AI and would be superseded by machines. This is what Stephen Hawking has declared, and we all need to take care of so many things when we are using AI. Technology is always good, but we at the same time we have seen misuse of technology, misuse of social media, so many things we all are knowing. Social media is very helpful. At the same time, there is a lot of misuse of social media. Even sonography, it is very helpful, but sex determination is done, then it's not, it's misuse. So many things are there. So we need a proper use of AI. Thank you very much for your patient hearing. Thanks a lot for giving this opportunity. And I'm so happy to see Dr. Sanjay Gupta sir and Dr. Narendra Malhotra and Dr. Sonawala sir are here. Thank you.
Thank you, sir. It was an excellent talk, and hopefully it should not take, AI should not take human brain. That is what, because it's still the personalized touch is the thing which we doctors feel that should always be there. So it was excellent. I'll request Dr. Sanjay Gupta sir to comment on this.
Sure. So, quite an exhaustive talk covering everything that's possible that AI should be and would be doing. I think most important point here is the data collection, and we have to learn data collection because AI is entirely based on data, and unless we have our own data, the AI is not going to be helpful to us. But Dr. Alpesh, you have covered every single thing that's possible with AI, and that's going to be an exciting future for all of us. Thank you so much.
Thank you, sir, and thank you, Parul Bhai, thank you, Parag, thank you, Sarita, for giving this opportunity.
And thank you, sir, for sparing your valuable time and enlightening us. Yeah, Archana, if you want to say something.
Yeah, it was a very elaborative talk, as Sanjay Gupta sir rightly said. He did not leave a single place in medicine where AI cannot be used, from labor room to info
Alpesh,
cesarean.
AI should remain our servant and it should not be allowed to become our master. That is
Yes,
perhaps
that is
everything.
true.
Yes.
It should help us, but it cannot replace the clinician, sir.
Yes, yeah.
Alpesh, very well presented. And the point raised by Parul is very, very valid. Artificial intelligence has to be for our assistance. The intelligence should be ours.
And we should not be dependent on that. That is
Absolutely.
because what we are seeing that previously we used to hear a fetal heart with fetoscope or with stethoscope. Now I think no, our juniors, they must not be knowing also that there is some fetoscope with which we can hear this, fetal heart. So that is where it is all replacing. But I think the human touch should be there. That is what I feel, and it should be done. So thank you, sir. Anybody wants to add something? I saw Dr. Yeah, Shobha madam.
नहीं, कोई और बोल रहे थे शायद, सरिता कोई बोल रहे थे।
नहीं,
अच्छा,
आप ही बोलिए।
हाँ, नहीं, I just wanted to say that Gupte sir very rightly said that, today what is required is data collection.
Good quality data. Good quality data.
Yeah, correct. Just yesterday, Alpesh bhai, you were also there, connected online with Dr. Arul Kumaran when we had this session organized by Janitri. Yeah. So they also have a lot of AI-based equipment. Not that is the only company which is doing it. Now, there are many industrial partners which are coming forward with this technology, wherein they have sensors, they have devices, they have, they have equipment which will help us to collect data, to monitor our women better, and pure data can be collected. So in that, AI-based applications are there. And correctly, as Dr. Alpesh bhai brought out, a lot of labor room interventions were AI-based data. What I am just trying to say is, maybe it will help us in our research and, formulating our research topic, and also coming out with good concrete data which are based on Indian women, because today that is one thing which is lacking. Considering the number of births and the obstetric population that India caters to, it's the largest in the world. 26-27 million deliveries per year, to say the least. It is the largest in the world. So especially for the obstetric pregnancy and labor data, AI is going to be very, very, very useful. And I think,
I was there in yesterday's meeting.
That is what.
And they have 3-fold medical devices using AI. Particularly, they have machine for the shock index, measuring shock index. They have fetal ECG machine. So many things are there, and this ambulatory fetal heart rate monitoring machine is also there.
Yes,
so many machines they have, and they are planning to come with many, many more. But of course, so many companies are there, and in near future we are going to have so many new medical devices. We cannot prevent it. We have to teach ourselves about all this technology. But at the same time, yes, they are only for our health. These devices are.
Yeah, they can alert and predict us so that we can take a decision at the right time. That is what I feel should be learned. Anyway, thank you so much. Parul sir, anything else you want to add?
No, but I just want to, as a thought-provoking idea, I suggest all of you to watch one beautiful movie, The Bicentennial Man. That was by Robin Williams. He is no more now. Bicentennial Man, by and large, is talking about what Stephen Hawking was worried about. And it's a real thought-provoking movie. All of you please see, is entirely on AI and humans. Okay.
Actually, Parul bhai, I would say medical organization like IMA, Foxy, FIGO should come out with the regulation about the role of AI in obstetric gynec or in healthcare.
Correct.
and we should advocate this regulation to
No,
government.
but see, we can put regulations for mobile use. Who is going to follow? Same
That
thing is
is
going to happen. If things are making your job easier, people are going to use
People will go into
it. That is okay, but if we are not going to make any regulation, then it will be a very pathetic. So at least whatever possible, one should try.
Yeah. Regulations, yeah.
And I think FIGO
I
is
think,
going to
yeah,
I
it will
think
come
already
next
FIGO has
step.
discussed about it, and I think FIGO is going to come with some regulations.
Okay. So
Well,
now we have.
Yes, please.
No, yes, sir. Yes, sir.
No, I was just saying that what was the time frame? I think we have some time left. You can discuss, otherwise we can wind up.
Yeah, now it is 6. When
Hmm.
we are
We are
over time.
beyond that, no?
Yes. Yes, sir. So I think
But
we should conclude the session.
yes, please.
You know, I'm Pratibha. I'm
Yeah,
reminded
madam.
of something which Dr. V.P. Paili says always. And he's a very senior teacher from, I think everybody knows Paili,
Yes,
sir.
yes, you
And
know.
whenever such issues come, no, he will say clinical discussions will be always like this. They will always be incomplete, you know. You should just decide that it is over for the day. That's all. And then
Anyway,
wait
but
for
it was
another
very
opportunity.
interactive, very
Very
interactive
nice.
session.
Yeah.
Very
I
nice.
enjoyed this.
And
Thank you.
really, I want to thank our speakers, Dr. Narendra Malhotra sir, Dr. Alpesh Gandhi sir, Dr. Ruma Sinha
Ruma.
for such excellent talk. And chairing the sessions, Dr. Kuldeep Singh, Dr. Sita Pal, Dr. Kanika Batra, Dr. Gaurav Desai, Sanjay Gupte sir, and Dr. Archana Kumari for such interactive session. Along with this, Dr. Shobha Gudi was there, and Dr. All ICOG chair, Dr. Parul Kotlawala, I want to thank him, and Dr. Parag Biniwala, incoming chair, and Dr. Sarita Bhalerao, who is the key source for this program. So I would like to thank everyone, and above all, I want to thank for giving me this opportunity to conduct this program.
Dr.
So with this, we
Sonawala
come.
sir is here from very
Yes.
Yes, and
I
Dr. Sonawala
noticed
sir.
that he is there.
Yes.
Sir usually attends all ICOG programs.
Yes, yeah. And Dr. Sonawala sir, yeah, he's there. Still he's
Pratibha,
there.
very well arranged program.
Thank you, sir.
You must keep on contributing like this.
Thank you so much. Thank you so much, sir.
Thank you.
Thank you.
Thanks, everyone.
And we should have such programs more. And I think Dr. Sarita madam is a little bit busy. So we'll conclude and we'll finish this program here. So good night. Let us switch it off. Yeah. So good night and bye from here.
Bye.
Bye-bye.
Bye. Bye.